Good afternoon, Kuresh, and thank you for giving me such an interesting and unusual topic to give, which I've never given before in my life. So here goes. Um, so I looked at these are kind of stories. These are patients that have been seen by me right when I started over the past 40 years. So I've reconstructed some of the details because I may not have exact fundus photographs and things like that. But all these cases are true. They are true stories. Okay. So normally, as far as history is concerned, if you go back to your MBBS, remember a history examination, investigations, and then diagnosis and management, and it looks like a linear thing, but it isn't a linear thing at all. In fact, it is a continuous process where the history informs your examination, the examination informs your investigations, and the two together again reinforce or re-clarify the history that you need to take before you reach your diagnosis and management. So it is a continuous process, not just at the beginning of your examination of the patient, but subsequently over the course of the disease as well. You need to go back and look at things as well. I just thought I'd put a slide up here just on simple symptomatology. It's useful to divide neuro-ophthalmic history, separate them into categories. As you know, afferent issues are always vision related or field related. The efferent issues are usually diplopia, double vision of some sort or the other. And then we have other history as well, which is basically CNS, which is focal or general deficits. And then certain other general histories. Don't forget pain, presence or absence of pain or headache, presence or absence of proptosis. Orbit is something that we miss out a little bit. And other histories, whether it's social, past medical, surgical, etc., etc. So I just thought I'll just complete this in one slide and go over some odd stories first of all. So this one is called, you know how it is in Iraq. This was a 25-year-old male who presented. I saw him in 2007 or 8, and he said 2 years I've been having reduced vision. I was hit on the head by a soldier during a demonstration, and he lost vision in the right eye. So the right eye had no PL, and there was a scar over the right eyebrow, and pupil which is grade 3 RAPD, and an optic atrophy. All very simple. My only question was, this patient straight away had, like Dr. Kuresh said, MRI. Yeah. Okay, MRI you go and do, and then refer to Dr. Navin JAYAKUMAR. So the question is an MRI really required in this particular situation for a post-traumatic optic atrophy of 2 years duration? Okay, so these are the questions that we thought of asking. So let's take a look at the history now. So since everything was done for me, I asked him, what is your history? So he said, in Iraq, the patients, Americans pull out you for questioning, and because of some resistance, he was hit on the head, and he lost vision gradually over 6 months. And they said, what is this? You can't lose vision gradually over 6 months after an injury with the butt of a rifle. Okay, so this diagnosis is not quite right. So the field was not yet done. I did a confrontation field. As you can see, one side you can't see, the other side has a temporal hemianomic defect. This was what was reported, that the left optic nerve was normal. Take a closer look and you'll see it's a bow tie optic atrophy, and the MRI predictably showed a large pituitary adenoma with chiasmal compression. So the story turns. There you go. So what did we learn from this particular story is, first, just ask the patient to say it in his own words. Don't put words in his mouth. Secondly, review the history again after your clinical examination and findings. If you saw a temporal hemianomic defect, go back and ask the history. Is it really trauma or not? And there should be some rationale of investigations. Yes, MRI would have been required in this case, but not before doing a visual field or even thinking about anything else. Okay, so it's not a knee-jerk reaction. Let's take another patient. This was when I was in Netralia at 5 o'clock in the evening. And I think there was some cultural program, therefore we all had to stay back. And it so happened that there's a patient who just drove into the emergency and said, I can't see. I was driving nearby, and he felt his vision go down. So he came and he had PL in the right eye. Pupil, barely reactive. Everything else is normal. Look inside his fundus is absolutely fine. What is the diagnosis now? Is it retrobulbar neuritis? Is it PION? Because he's 32, PION doesn't really fit. Ishihara on the other side was normal, confrontation feels normal, fundus is absolutely fine. Okay, so here is patient sees nothing, doctor sees nothing, which is very typical of optic neuritis. Is there anything else that we can ask? Okay, so this is the history. I was driving nearby and suddenly felt my vision become dark over a few minutes, so I drove straight to the hospital. No headache, no aura, no amaurosis, general health good. But the fact is, vision dropping over a few minutes is not a sign of optic neuritis of any sort. It indicates an acute ischemic emergency. So this is wrong. Okay, so this patient, we thought he had CRAO, and it was so early, in a few minutes after CRAO developed, which is very unusual for you to see such a patient. So the retina was normal. There was no cherry red spot, nothing happening. There's only no vision and an RAPD. So we did some massage, paracentesis, everything, and after half an hour, just vision said, I'm feeling a little better now. Next morning when I saw him, the vision was 660, and then he became okay. Did the tests for CRAO, and he had a mitral valve prolapse, which probably explained why he ended up in this situation. So this was not retrobulbar optic neuritis. So detailing the history is important, and you recognize the fact that this is an emergency. And sometimes, as in this case, unlike the previous case, treatment may precede any investigations that you do. So you must be agile enough to switch things around a little bit. So this was when I was at Wilmer with Dr. Miller. This is Dr. Miller's story, actually. He was seeing patients, we were seeing patients, and his fellow walked in and said, oh, I have this patient who has double vision since 1 month, and he fell off a ladder because he was painting the roof of his house, and so the diagnosis is sixth nerve palsy. So everything is fine except the sixth nerve palsy. Okay, CNS, everything, patient is all healthy and otherwise fine. So any other investigations are needed now or not? So Dr. Miller is one for taking very, very detailed history and ability to recall the history of all his patients at the end of the day as well. That way. So the history was that Dr. Miller asked exactly what happened. Oh, he was painting the roof. He was climbed up the ladder and went there and thing. So, okay, so where did he fall from? He fell from the first rung. Okay, so now if I slip here and hit my head here, I'm not going to get a sixth nerve palsy. Maybe, but very, very unlikely. Okay, so this diagnosis is query. So again, he said, let's go and get a scan done, and the scan showed a large tumor in the petrous apex, which is pressing on the sixth cranial nerve. It had not yet produced a sixth nerve palsy, but the nerve is stretched over the tumor and is ischemic. It's not yet symptomatically a sixth nerve. Therefore, a trivial injury, such as just this falling, has damaged an already compromised sixth nerve, resulting in a palsy. Okay, so this can also happen. So again, detailing the history and critically evaluate the history. Okay, you fell down from where, how, what? Ask those questions as well. Okay, so home improvement, be careful. Okay, this is a patient, endless confusion. Who actually had no problem. 16-year-old boy, he says, I'm fine, I just went to the doctor for glasses and they made all sorts of noise, and finally the patient ends up with me. No vision problem, he has a little bit of photophobia, and his vision is 360 distance, N12 near, for the past 6 or 7 years. I said, have you had any recent drop in the vision, any amaurosis? Nothing. I'm perfectly fine. That way. Color vision is 0. Okay, so now these are the discs. Now it looks like papilledema. Now the question is, if it is papilledema, are you dealing with IIH? Where is the aura? Where is the thing? The vision doesn't fit that. More importantly, photophobia. A distance vision is very impaired, but the near vision seems to be reasonably okay. He doesn't perfectly well in school. So all this doesn't fit that way. So he obviously has some kind of a macular cone dystrophy, photophobia, poor absent color vision, etc. So the whole thing didn't fit together. So we sent him for an MR for IIH, and unfortunately Dr. Veena, our radiologist, said everything is fine including the MRV, there's no venous sinus stenosis at all. So then we did the ultrasound, is there a drusen hidden somewhere, everything is fine. I said, let's start him with Diamox. And with Diamox, he improved symptomatically. The disc edema went down. So now that tells me that yes, this was an IIH as well that way. So finally, over back and forth, because his treatment was irregular, he used to miss stuff and all that, and we finally said, let's just get an LP done. Confirmed the diagnosis, 320 millimeters of water. The DSA showed a stenosis with a very significant pressure gradient, so he had a stented, and now the disc edema has gone down over the past 3 or 4 months that way. So there is this famous William of Ockham who came up with his Occam's razor, that if you have X, Y, and Z things, try and put it all. There may be one diagnosis which explains everything. Occasionally, there are exceptions to Occam's razor, where you can get two different diagnoses existing in the same patient. So just separate out the history. Photophobia is not a feature of papilledema. Okay? If optic neuropathy was happening over a papilledema, some kind of vision issues going into atrophy, if distance vision goes down by X, the near vision will also go down by the same X amount. You can't have one better and the other worse. Okay? All right. So this is again back in my SN days, 38-year-old patient from Malaysia who had sudden visual loss in the left eye for a few days. So the left eye was counting fingers, red desaturation, RAPD, fundus is normal. Yes, this is optic neuritis. In those days, this was before ONTT, so oral steroids was given. Oral steroids, very, very happy. Okay, no neuroimaging those days. We just used to wait and see, and oral steroids were given, and then his vision improved very, very nicely. And we told him, you taper the steroids and come for the review. So he used to go back home to Malaysia and come once in 6 months or so. If you look at the reviews, and those days fields used to be done by Goldman perimetry. So the optometrists used to draw the outlines, generally round, nothing to stir you, except that by the time 18 and 24 months had come, that 6.6, which you could explain as 6.9 plus, okay, 6.12 plus, maybe it was 6.9 before, nothing much happening, but then 6.60 you can't explain it. Okay, and then you look at the old Goldman fields and look at the present one, and you can see that slow depression happening on the superior temporal aspect of the left field, and therefore he had an CT done those days. So this cannot be optic neuritis, and the CT showed a pituitary adenoma with a pituitary apoplectic spot in the center. When they did the surgery, they found hemorrhage there, and what had happened was the bleed suddenly increased the size of the tumor, which suddenly pressed on the optic nerve, causing an optic neuritis-like picture because of ischemia to the optic nerve. It just pressed on it suddenly. The perilesional edema did that. The steroid improved the perilesional edema, and therefore the vision jumped back. No optic neuritis can improve from 1 meter to 6.6 over 24 to 48 hours. If something improves that fast, it is not typical optic neuritis, something else altogether. So again, review the history. It's a continuous process. This is over the course of a disease as well. Okay. Okay. VIPs. This is again, they told me that someone's coming, the ADC to the governor, young chap, and I'm waiting from him since the morning, but no sign of him until 4 o'clock in the evening. He had ptosis, so he was seen by oculoplasty, who then said, okay, there's nothing oculoplastic about it, go and meet Dr. Navin. So he came in, and he had a mild ptosis in the right eye with some neck pain, etc. He was an athletic chap. And there was no fatigue signs, no ocular motility issues, pupils are brisk, etc. So I said, okay, this is maybe partial third nerve with pupil sparing. Obviously, I need to do MRI with MR angiogram. And I said, I'll review tomorrow. The only thing I did different was, what happens if this VIP comes to me tomorrow with a normal MRI and an MR angiogram? What are you going to do now? So I said, okay, I would probably do the blood counts, ESR, the PPBS, everything. Hopefully, if that comes out normal, I'll put him on a steroid and then hope for the best. Okay. So we did the CBC, ESR, ANA, and PPBS. Just give the blood now before you go for your MRI, and we'll see you tomorrow morning. So I'll have everything with me tomorrow to discuss. Next morning, I go to Netra, all hell breaks through with Dr. Badrinath's office. I'm saying, now I'm wondering what have I done wrong this time, because VIP is the one where you get into trouble. Then they've actually, there's something wrong with the lab. They've gone to call the patient again back in the night. They've taken the blood again and checked, and the MRI was normal, and the blood count was 78,000. Okay, so he had a leukemia. Then they told Now Navin will talk to him, and he had brought his wife along. So I spoke to them. I said, I'll give you a letter to the hematologist. So start dictating the letter. Okay, history, this, vision. Next page, turn around, IOP, slit lamp, and where's the fundus? Because it got crossed across, the protocol was broken. Normally we would dilate and see, but because Navin JAYAKUMAR is going to see pupil, they didn't dilate. I thought they'd already seen it and come and met me, so I didn't see the previous page. So I said, wait, let me dilate your eyes and look at the pupil, at the fundus. And this is what the fundus showed. Okay, so there is a reason why we follow a protocol. It makes an ordinary ophthalmologist a good one, and a good ophthalmologist a great one, just if you just follow the steps that way. And it's worthwhile in this case. I always go back and think, how did I diagnose this patient with leukemia with a ptosis? And the thing is, just you thought a little ahead and said, okay, let's do this as well in the investigation. Simple investigation. This, unfortunately, also recently, 74-year-old gentleman, sudden painless loss of vision on the right eye over a few days, and he had a similar loss in the left eye 2 months ago. And someone said retrobulbar neuritis. What had he done? Just did a PPBS, put him on oral prednisolone, and then sent him. Nothing else was done. So his left eye is PL. The right eye now is counting fingers, sluggish. Fundus is normal. Okay, left eye is optic atrophy. I checked his, because of the age, I thought arthritic AIO1. I just checked his superficial temporal artery. It was prominent, but he's a thin gentleman. No pain or anything else like that. So what do? Normally in these cases, I ask only for the ESR and let the rest of the tests come, and then I start them on steroid immediately. I don't need to wait for ANA and things and C-reactive protein to come. This is an emergency. So I just look for the ESR number and then go ahead. So I said ESR, put him on a steroid, and I said, let's wait for the other things to come. That way. Now, the thing was, ESR is 72, C-reactive protein was raised, hemoglobin was thing, thrombocytopenia, and the WBC count was 122,000. So this was not, I was full of righteous anger at arthritic AION without ESR C-reactive protein. How the hell did that person do this and just put him on oral steroids and come? I was also mistaken. Certain features are suggestive of arthritic AION, but certain other features like absence of pain, absence of other things should alert you to some other reason than arthritic AION. This patient had acute myeloid leukemia at all as well. So just correlate the history and the examination, and it's worthwhile considering some kind of a reasonable differential diagnosis. So back to my first slide. I think as far as history is concerned, listen actively and patiently to the patient, use the patient's own words to assess it, detail, reassess, clarify, and look at the previous records. As far as examination is concerned, what have you learned? Don't skip the protocol, just do it step by step. Get your technique in order and try and correlate with the findings. Investigation, simple things. What can you do in your room? Color vision, confrontation, Quresh said exactly, diplopia charting. Stepwise, you don't need to do all investigations on the earth at once. Grade it and do it step by step. And always when neuroophthalmology, there are multiple things including MRI and all sorts of things, very expensive. So it's good to take the patients into account and tell them why you're doing these. And you take the patient along your journey of trying to find out what the patient is suffering from. It will go a long way in patient confidence in what you're up to that way. So 2 people from Johns Hopkins, separated 2 centuries apart. William Osler, the father of medicine, who said, listen to your patient, he's telling you the diagnosis. And in the 1980s, Andrew Lee, my good friend and neuro-ophthalmologist, who said history is not everything. Sometimes it's the only thing that helps you. Thank you.